Hello and welcome to a session of the Center for Podiatric Education. I wanted to speak a little bit about orthotic management of common forefoot problems, and in particular in this session I'd like to address my philosophy on the use of orthotics for the management of first metatarsal phalangeal joint problems. Now, this discussion is going to be a clinical discussion, and it's going to be based on my personal perception, and I certainly would encourage the listeners to pursue more detailed discussions of this subject by people such as Doug Ritchie and Robert Phillips and others who are experts in the area of biomechanics. And I wanted to just share my own personal philosophy and experience, which compared to these individuals I'm sure will be rather simplistic. I've seen this quote attributed to German chemists. I've also seen this quote attributed to Yogi Berra, that in theory there's no difference between theory and practice, but in practice there is. And when it comes to the day-to-day management of bunion deformity and hallux limitus with orthotics, I do believe there probably is a difference between theory and practice. We see a variety of forefoot problems in podiatric medicine for which we employ orthotics as well as non-custom orthotics. And we see various arguments raised for the treatment of all these problems with orthotics. If you attend various podiatry seminars, you see a variety of theories put forth regarding the biomechanical etiology for a variety of pathologic conditions and various facts or justifications, if you will, for the use of these differing orthotics. And indeed, we do see a variety of theoretical propositions put forth. And when I listen to these various individuals who declare types of biomechanical theories to justify various orthotics and devices, I ask myself upon what observations or scientific data do they base their impressions. So we have hypotheses and we have theories. Now, many of the arguments that are advanced, in my opinion, in this profession for use of specialized orthotic devices are more hypotheses than they are theories or fact. That is to say, we have people asking us to purchase, to utilize various devices that they are selling or have some financial interest in, and it's really based on very little, very limited evidence. Generally, these devices are not scientifically tested or proven. The theories and devices are based on very limited data, although a hypothesis can lead to a theory. Now, a theory is different than a hypothesis. A theory is an idea that explains facts or observations. Theories are scientifically tested and proven. They're based upon a wide range of data. They may be initially formulated through a hypothesis, but eventually based on data that is accumulated. And really, theories are our best explanation of observations. So when it comes to biomechanics and biomechanical explanations and treatment for forefoot pathology, the first thing we of course want to do is establish a diagnosis. I then generally consider confounding factors. Is there equinus present that has to be addressed? Is there a pronation deformity or a cavus foot deformity? I try to establish as best I can whether or not there is evidence of first ray insufficiency, recognizing that this can be difficult to quantitate. I look for metatarsal length abnormalities in treating forefoot problems. I look for confounding factors such as fat pad atrophy and hammer toe deformities with prolapse of the metatarsal heads. I think all of these things, as you know, are operative in forefoot symptomatology. I actually document these as separate diagnoses and attempt to communicate these back to the primary care physician so they understand that these are not always simple problems, but oftentimes forefoot pain has multiple components that need to be addressed, so that we may, for example, have a diagnosis of equinus and the incorporation of some type of stretching program or even surgical lengthening at times of the gastrocsoleus muscles as necessary, maybe shoe modifications or inserts to account for that equinus. And that treatment is in addition to perhaps orthotics for control of the pronation deformity or stabilization or accommodation of that first ray insufficiency and so forth. So what are our general principles for use of orthotics for the management of forefoot pathology? Generally, I'm using it to reduce pronatory instability, that is to say to limit pronation, at least in the subtalar joint. I want to stabilize the first ray. I want to incorporate in that device efforts to accommodate any forefoot deformities which require accommodation, and when necessary compensate for the fat pad atrophy. Now in a normal foot, we know that the theoretical normal foot, the heel is basically perpendicular to the supporting surface, and with the heel weight bearing, the forefoot is perpendicular to that heel and fully weight bearing. So the entire forefoot is weight bearing on the ground, the heel is weight bearing perpendicular to that supporting surface, and this is the theoretical normal foot. If we have a pronated foot structure, what do we see? Well, the patient's weight bearing and the forefoot is still on the ground, 1 through 5. However, the heel is in valgus. And so obviously, if we've gone from heel perpendicular weight bearing with the forefoot 1 through 5 on the ground to a position where the heel is now in valgus and still weight bearing and the forefoot is still weight bearing, a twist has occurred somewhere in that foot between that heel and that forefoot to allow us to maintain weight bearing with the forefoot and heel, with the heel no longer in a perpendicular position. So we refer to this as various forms of compensatory pronation. And we really have two basic competing biomechanical deformities, or explanations, that is, for these deformities. And both have reasonable theories behind them. In classic Rootian biomechanics, if you will, the work that was described in detail by Root, Weed, Orion, and Scarlato in the classic compendium of podiatric biomechanics, which was a well-referenced textbook and had many references from kinesiology and physiology from many other authors, so that these were not concepts that were all originally those of Merton Root, but rather were expanded by Dr. Root, Weed, Orion, and Scarlato, and brought to light to our profession. But we were generally taught that, as a rule, the primary deformities in the forefoot occurred because of deformity in the hindfoot, that is to say that subtalar joint instability because of a position of pronation leads to instability of the midfoot and forefoot instability and deformity, so that the hindfoot usually dictated positioning and deformity and symptomatology in the forefoot. If, on the other hand, you are a person who subscribes to the theories of Morton and Lapidus, then your thinking is quite the reverse. Older chiropodists remember the term medial column instability, or medial instability of the foot. And this suggested that the primary instability was actually in the first ray, and that with instability of the first ray, the foot would collapse, and that the heel would go into valgus secondary to instability of the first ray. So these are opposite theories. They are diametric. One saying hindfoot controls the forefoot, the other saying no, in some circumstances the forefoot controls the hindfoot. So we have this suggestion by those who subscribe to theories such as those of Morton and Lapidus that a primary instability exists in the first ray being unstable collapses, and this leads to secondary heel valgus and mid-tarsal joint changes, and that the primary stabilization should be directed at the first ray rather than the subtalar joint, and that the primary deformity is medially and distal, not in the hindfoot. And we see this reflected in the writings of Dudley Morton and Paul Lapidus. And much of this thinking has been advanced by the people who train in the Pacific Northwest, who frequently employ procedures such as the Lapidus procedure as part of flatfoot correction. Paul Lapidus' thought was that the primary deformity leading, for example, to a bunion was the increased intermetatarsal angulation between the first cuneiform and first metatarsal. If, on the other hand, you are a classic root biomechanist, if you will, for lack of a better term, then you're taught that the deformity occurs in quite the opposite manner. That when the subtalar joint is in a pronated position during the stance phase of gait, the foot becomes hypermobile secondary to that subtalar joint pronation, and the most distal segments become unstable due to this hindfoot pronation. In the case of a bunion, or hallux limitus, which is what we would like to speak about with this session, we know that when the subtalar joint is supinated, or at least in a neutral position, we have a vertical component to the peroneus longus, which of course inserts into the base of the first metatarsal and first cuneiform bone, so that when this muscle contracts, it has a downward vector of force as well as a lateral vector of force, and it causes the foot to be stabilized in the medial column. And this imparts some significant degree of stability to the first ray. Conversely, when the foot is in a pronated position, several things happen. The cuboid is now unstable. We lose the vertical orientation of the peroneus longus, which is now more horizontal in its insertion into the base of the first metatarsal and first cuneiform. So we don't have that downward stabilizing vector. We have increased weight bearing medially when this foot is being pronated. So as a result, the first ray loses the stabilizing effects of that peroneus longus and becomes unstable with weight bearing. So that we're taught that first ray hypermobility is related to the extent of subtalar joint pronation, and the extent of calcaneal eversion is associated with subtalar joint pronation. That when the subtalar joint pronates, there is a loss of osseous stability of the cuboid and forefoot. There's diminution of peroneus longus function, and then secondarily with this instability, other aggravating factors such as weight, ligamentous laxity, shoes, and so forth become operative. So that if we are a classic root biomechanist, we're looking at that peroneus longus insertion, and we're saying that when there is a more vertical component with a supinated subtalar joint, the cuboid is stable, it is more inferiorly placed, we have a more vertical component to the pull of that tendon, and as a result, the first ray becomes more stable. And this rotation, of course, occurs around the axis of motion of the first ray. Now, where exactly first ray instability occurs can be subject to some discussion. Here's a patient who had undergone a calcaneal osteotomy for a pronation deformity, and while the foot has been stabilized by changing the position of the heel, we have gapping with weight bearing of the obviously of the first metatarsal cuneiform joint. So in this case, in hindsight, we could look at this patient and say a better correction would have been obtained if we had incorporated a Lapidus procedure in the treatment of this patient. Notice that there is some malalignment of the navicular cuneiform joint, but we clearly have gapping here of the first metatarsal cuneiform joint. On the other hand, we frequently see patients where the metatarsal cuneiform joint appears to be relatively intact and the majority of the deformity appears to be at the navicular cuneiform joint. So from a surgical perspective, gapping at this level would require a Lapidus procedure, whereas in theory, gapping at this level would require a Hoek arthrodesis. And I myself have always been an advocate of the Hoek navicular cuneiform fusion in the treatment of some of these deformities over time. So what about the use of orthotics for a bunion deformity? Where do I feel that these fit in? Where do I feel this would be helpful and useful for the treatment of various first-ray deformities? And here we see an example of bunion deformity in the juvenile patient, another in a young adult. Well, my own thoughts on orthotics and the use of orthotics for the treatment of first-ray deformities are listed here. Number one is to prevent the progression of the bunion deformity when it is caught early, particularly in the juvenile and young adult, to limit pronatory effects and the effects of first-ray instability, whether that's primary or secondary, and try to prevent joint adaptive changes and progression of that deformity. Over the years, there is no question in my mind that orthotics have been helpful for some patients in reducing bunion pain and following surgery, particularly in the patient with significant pronatory disability or instability of the first ray, trying to prevent a recurrence of that bunion deformity. There aren't many studies that one can point to looking at the use of orthotics for the treatment of bunion deformity. This particular study was published in Journal of the American Medical Association 16 years ago, so it's a rather old study looking at bunion patients and whether they did well with no treatment, the use of orthotics or surgery. And 46% of patients studied reported reduced pain in their bunion deformity at 6 months and 1 year with the use of orthotics. Where is it that I look to use orthotics? Well, the first is sesamoid pain. Many patients with bunion deformity do get pain in the area of the sesamoid, particularly when the sesamoid is crossing over the crista, so that we see the sesamoid on X-ray at position 4. The patient has plantar pain, and I find that not infrequently we can utilize orthotics for the management of that particular component of their bunion pain, that being again the sesamoid in position 4 overlying the crista. Limiting pronation, in my opinion and my observation, has also been helpful for patients that have plantar medial nerve compression syndromes, and these are the patients that have a bunion and they have a hallux valgus, and they frequently complain of numbness or shooting pain or burning pain. Not infrequently, if you take the time to examine them, they have a positive Tinel sign or Vallot on provocation of the medial proper branch of the medial plantar nerve as it crosses under the bunion. Not infrequently, they have thickening of the skin under the metatarsal head, first MPJ or hallux IPJ. I found that in some patients, certainly not all, depending on the degree of pronation, the patient's weight, and other factors, but some patients do well in relieving plantar medial hallux interphalangeal joint callus and first MPJ callus pain with the use of orthotics. And then there's this question of whether or not we can interdict the progression of the deformity. So feet like this are examples where I will attempt the use of an orthotic. The patient is pronating onto that plantar medial first metatarsal head. We see rotation of the hallux. We see an early bunion forming. And if the patient has pain from jamming of that joint, where they have plantar medial first MPJ pain, not infrequently an orthotic will be helpful. Now, oftentimes we must incorporate other therapies, such as stretching of the gastroc soleus, perhaps a topical anti-inflammatory, but certainly there's a subset of patients with bunion pain that seem to respond reasonably well to the use of orthotics. This concept of plantar medial nerve pain, the medial proper branch of the medial plantar nerve as it passes here under the metatarsal head, which has been displaced medially from the bunion. This is something that we don't hear discussed much at the meetings, and yet we have seen some studies that suggest this is more common than we would suspect. This is a paper that by Heron and Associates that showed that in hallux valgus and bunion deformity, sensory symptoms occur in as many as 21% of patients, and sensory signs can be present or elicited in up to 44% of patients. And my own personal experience has been that in these patients, a significant portion do well with the use of a pronation limiting orthotic. Frequently I will combine that with a topical analgesic with medication directed at both nerve pain as well as inflammatory pain. My approach in these patients is based upon the Serafian twisted plate theory. That is to say, my preference is to supinate the subtalar joint and with an extrinsic post, and to pronate the forefoot with an intrinsic post. Now, purists will argue that this would not be appropriate, for example, for a compensated forefoot varus, and I'm not going to argue that position, except to say it's simply not consistent with my personal approach to this problem or these problems. So I will typically use a 4 to 5 degree hindfoot extrinsic post. I will typically use a 3 to 4 degree forefoot intrinsic post. In the old days, this was called cross wedging. We know that if we pronate the mid-tarsal joint up against the subtalar joint, when it is either in a neutral position or a supinated position, we lock generally that cuboid, the oblique axis of the mid-tarsal joint, if you will. This provides stabilization of the foot and hopefully provides a more vertical component to that peroneus longus and helps us to stabilize that first ray. There are some patients that seem to have or seem to function, if you will, around a more vertical oblique axis of the mid-tarsal joint. Those are the patients that have a significant amount of abduction. So these are the patients that you put in an orthotic. You feel that you've got them posted reasonably well in the hindfoot, and you look at their heel position and it's really pretty good, and yet you're still abducted and slipping off the orthotic at the level of the mid-tarsal joint. And it seems as though these patients take an excess of hindfoot supination to stop that subluxation of the cuboid, the oblique axis of the mid-tarsal joint. So in theory, these people are functioning around a more vertical oblique axis. I don't know how you prove that. I think one can determine that clinically by examining the patient, holding the heel where you'd like it in the orthotic, and pronating and abducting that midfoot. If you feel that cuboid, that mid-tarsal joint is still subluxing in a lateral direction, then you're likely going to have limited success with your orthotic. And thinking along those same lines, surgically, these are the patients in whom I'm much more apt to incorporate an Evans type of calcaneal osteotomy. But in any event, again, I'm going to go with a hindfoot varus extrinsic post 4 to 5 degrees. I'm going to go with an intrinsic valgus post 3 to 4 degrees. I'll then incorporate accommodative forefoot materials as needed. Generally, there's going to be an equinus present, and I will instruct the patient to utilize gastrocsoleus stretching or perhaps a night splint. We make appropriate shoe recommendations, and then we try to address other extrinsic factors that may be contributing to pressure to that bunion on the plantar medial aspect, altering shoe selection perhaps, or asking the patient to lose weight, perhaps reducing edema. I generally will reserve surgical intervention for those patients that are having significant pathology and fail non-operative management when non-operative care seems to be appropriate. Following first ray surgery, there are certain problems that we tend to see, including lesser metatarsalgia, hallux limitis, perhaps loss of the peroneus longus stability, or we may sometimes see excessive shortening of the first metatarsal with lesser metatarsalgia, hallux hammertoe, hallux malleus. Again, in those patients, I'll go ahead and once again use an extrinsic rear foot varus post. In those circumstances, when important, I'll do a first ray cutout depending on the particular circumstances to drop the first ray down. I do not like to load up under the first ray. Again, I generally will incorporate an intrinsic forefoot valgus post, and then whatever padding or accommodative efforts are needed to go ahead and offload the transfer metatarsalgia, whether it's some type of incorporated aperture padding or strip padding, metatarsal padding, or so forth. Now, when there is shortening and transfer metatarsalgia, my efforts are really made to drop the first ray, and I really am always reluctant to place anything underneath the first metatarsal. Now, this makes sense in theory to increase weight bearing under the first metatarsal, but generally when we add posting and elevations under the first metatarsal head, this results in increasing limited motion to that first metatarsal. This was an old ad from the Chicago School of Chiropody, interestingly enough, and it's referred to as a dignified, lucrative profession. Now, as far as hallux limitis goes and orthotics considerations for hallux limitis, I would again refer you to the more extensive and detailed lectures of those with significant expertise in biomechanics. So I'm going to give you my own personal approach to dealing with hallux limitis, both functional and structural in terms of the use of orthotics. So hallux limitis is basically a form of biomechanically induced osteoarthritis. And that occurs under two circumstances. We could either have abnormal forces applied to a normal joint. For example, we have a normal first metatarsal phalangeal joint in a significantly pronated foot, or we could have normal forces applied to an abnormal joint. For example, we have patients described by Root with congenital elevation of the first ray. We have, again, patients with pronation-associated syndromes, patients that may have an elongation of the first ray or have first ray immobilization associated with tarsal coalition and or a limited subtalar and mid-tarsal joint motion. There are also some secondary soft tissue contractures that occur. When a patient develops hallux limitis, they have pain on dorsiflexion, and oftentimes the body will engage in efforts to limit that dorsiflexion that's causing pain. This can include a tonic contracture of the anterior tibial tendon contributing to or even causing first ray elevation. Similarly, some patients will develop a tonic contracture of the flexor tendons to their great toe in an effort to avoid dorsiflexion and pain. As a result, the lateral x-rays appear to indicate a plantar flexion positioning of the hallux with what appears to be elevation of the first ray. The patients will walk with an abducted, externally rotated gait with their first ray elevated in an effort to avoid compression of the toe joint itself and resulting pain. One of the intriguing questions, as I mentioned earlier, is where does first ray elevation occur? Is it always at the navicular cuneiform joint? Is it at the first metatarsal cuneiform joint? Do we have patients with combinations of these deformities? There are procedures that have been around for some time for the treatment of flat feet. They are of historical interest, but they were, for example, efforts to improve the classic Hoke navicular cuneiform arthrodesis by concurrent fusion of the navicular and cuneiform first metatarsal joint. Perhaps the older individuals in the room or those who are more well-read will remember the Miller procedure, and that's exactly what you were looking at, or efforts to stabilize that entire medial column. Again, the principles regarding the effects of pronation and supination on the orientation of the peroneus longus and its ability to stabilize the first ray are in effect. Some other issues that are involved: we know that when one dorsiflexes the ankle joint, there is decreased great toe range of motion, and when we plantarflex the first ray, or rather the ankle joint, this increases the range of motion. As a result of that, again, particularly in hallux limitus cases, I incorporate an extrinsic hindfoot posting in an effort to gain some dorsiflexion. I will use a pronation limiting orthotic once again with an extrinsic hindfoot varus post somewhere between 4 and 5 degrees, and an intrinsic forefoot valgus post 3 to 4 degrees. Now, I understand that this is something of heresy in the sense that it does not correspond to specific compensatory deformities. So I'm not saying that I don't do this with, say, a compensated forefoot varus, or change my orthotic with a compensated flexible forefoot valgus or a compensated hindfoot varus. This is what I do typically on the majority of patients, with few exceptions. We also know that Tom Rukas proposed many years ago that if we place materials underneath the first metatarsal phalangeal joint, we will decrease range of motion. And again, this is one of the reasons that I cut out the first ray for hallux limitus deformities and place the forefoot in valgus. Other orthotic efforts that can be utilized to manage hallux limitus would include graphite plates that are sometimes utilized for turf toe, which will stiffen the shoe, prevent bending, and sort of act to splint the first metatarsal phalangeal joint. Rocker bottom soles on shoes are frequently helpful because they decrease dorsiflexion demand to the great toe joint, and therefore reduce the amount of dorsiflexion and dorsiflexion related pain. So for functional hallux limitus as well as for structural hallux limitus, I will stabilize the subtalar joint with an extrinsic hindfoot post. I will put the forefoot in valgus with an intrinsic post. I will not infrequently cut out the first ray in these patients, and there are a variety of ways that one can do this. Not every system works for every single patient. We've seen a description of this kinetic wedge and similarly the Cluffy wedge. Personally, I'm not a big user of either kinetic wedges or Cluffy wedges. However, there are those who claim a good deal of success utilizing these devices. So in summary, in using orthotics for either bunion deformity or for primarily functional hallux limitus, My rule is to stabilize subtalar joint pronatory forces by using an extrinsic hindfoot post. Generally, you will find that forefoot varus posting is not helpful, and I will use an intrinsic forefoot valgus post. And when indicated, I consider first ray offloads by cutting out the first ray. Thank you.